we've known that now for several years, going on probably 10 years, that CAR CD19 directed CAR T cells are highly effective in patients who have failed, or I shouldn't say patients who have disease that has either failed to respond or progressed after 2 or more lines of therapy. And matter of fact, many of these patients have been multiply treated with far more than 2 more lines of therapy, and that and still had significant responses. And the hypothesis is, well, if we use this earlier in the disease course, would this be more efficacious? And particularly targeting a specific patient population of patients who have primary refractory disease to frontline therapy or rapidly recur after frontline therapy. And this disease population results have been relatively dismal, with long-term survival as defined by greater than 5 years is less than 25%. Now, the only caveat in this is you're selecting out for an extremely aggressive patient population. So with the hypothesis that if you use early might be better, may not apply because this is such a bad patient population. So there have been 3 major trials that have addressed this. And these results we are expecting to be the results of will be reported at the upcoming 2021 annual meeting of the American Society of Hematology meetings, which will take place in Atlanta in December. And the 3 trials are ZUMA-7, which uses the KITE CD28 directed CD19 CAR with a 401BB co-stimulatory domain. And then there is Transform, which uses the BMS product, which is also an anti-CD19 with a 401BB, but with a balance of CD4s and CD8s. Now, we have only seen press releases on these 3 trials, and 2 of the trials have demonstrated superiority of CARs over standard of care, which would be conventional chemotherapy and if chemosensitive autologous stem cell transplantation. And one of the trials did not show any difference in event-free survival. All 3 trials' primary endpoint was event-free survival. So we're going to have to look very carefully and compare these 3 trials, what their specific patient populations by trial design. They look to be relatively similar in terms of eligibility, but the trial designs there are subtle differences between the 3 trials. It does appear that just based upon the preliminary small amount of data that's been revealed so far, that CAR T cells are superior in this clinical situation. But I really think that we need to do a deep dive and a comparison so we can understand the biology of the disease and actually specifically identify if there are specific patient populations within that high risk populations which benefit more or benefit less.